Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Porto. Today, I will be discussing a challenging lupus case of a young woman with polyarthritis with Professors Andrea, Doria and Sandra Navarra from the Lupus Academy Steering Committee. Andrea and Sandra, welcome and thank you so much for joining us today. So let's go to the case. This case is a 34-year-old white woman that she has 3 years diagnosis of hypothyroidism. In January 2018, after sun exposure, she developed acute onset fever, asthenia, fatigue, photosensitive malar rash, oral ulcers, alopecia, arthritis, and myositis with myalgia and muscle weakness. Her blood tests showed leukopenia under 3,000, normal platelets, normal kidney function, low-grade proteinuria under 0.5 grams a day, high ANA titers, high anti-dsDNA titers, RNP antibodies positive. She has both low C3 and C4. Her SLEDAI-2K was 20. She was started on prednisolone 1 milligram kilo a day, hydroxychloroquine 400 milligrams a day, azathioprine 100 milligrams a day. During the next 3 months, there were no clinical symptoms and prednisolone was tapered off until 5 milligrams a day. August, so 7 months after the first presentation, she flared again with arthritis, oral and nasal ulcers, alopecia, Raynaud's, leukopenia, dsDNA was positive, low C3 and C4. Now, a SLEDAI was 13, and she was on prednisolone 5 milligrams, azathioprine 100, and hydroxychloroquine 400 a day. She increased the prednisolone to 20 milligrams a day, gradually tapered it off, 1 month later to 5 milligrams a day. And she stopped azathioprine due to gastrointestinal intolerance. But in November, 2 months after tapering prednisolone and being off azathioprine, she flared again with fever, oral ulcers, arthritis, myositis, leukopenia, dsDNA high, low C3 and C4, and she had new cutaneous vasculitis of both hands and feet and chilblain lupus. She did an infectious workup that ruled out TB, HIV, hepatitis B virus, and hepatitis C virus infections. And her SLEDAI was again 20. At this point, this woman is still in her first year of disease, 3 severe flares, resistant to standard of care therapy whenever steroids were tapered, but she had no major organ-threatening disease. So, Sandra, she is off azathioprine. How would you treat her at this point?
I would consider other DMARDs at this point, like MMF, for example, can be used, can be effective for these situations. But I would go right on, if belimumab was available, I would already convince her to have belimumab. For this patient who has a flare, and it's obviously a flare, you have a low C3 and C4, low complement, and you have double-stranded DNA, which is positive, so serologically positive. This is one patient who would benefit from belimumab.
Do you agree, Andrea? Do you have more insights to this?
Yes, I agree completely that again, it was patients with a relapsing remitting profile, which is an additional factor. Of course, I am not sure that belimumab will be enough. If belimumab will not be enough, we can add one of the drugs which Sandra mentioned, MMF or methotrexate, also because she had also musculoskeletal manifestation.
Yes.
Or some other things, but I think that to start early belimumab is more convenient.
she doesn't have major organ threatening disease, but she did really have a severe year with flares. In this scenario, do you consider giving her rituximab, or you rather first go with belimumab? Or would you want to induce her despite not having a major organ threatening disease?
Yes, I would do that. Actually, I would consider that. First of all, in our country, rituximab is readily available more than belimumab. And rituximab works faster. And there have been studies that have shown that the sequential use of rituximab, because it has a more widespread, not really widespread, it's a wider spectrum of a B cell effect compared to belimumab, wherein the studies show, sequential studies would show that you have rituximab. I think this is, was that Calibrate or one of those clinical trials that showed that you can have, it makes sense because they have a different set of B cells with rituximab, and then you do your induction for these patients at the onset to control the disease, and then you follow that up and maintain that with belimumab on the long term. And it makes sense for these patients who has failed the standard of care for these patients. And this is, when you get something like this with the vasculitis, that is disabling. So this patient would need something like that.
Sorry to interrupt. If you want to see the pictures of the vasculitis, you can go to the show notes of this podcast. Andrea, would you consider rituximab also, or would you go for belimumab straightforward?
I think that to use rituximab is a good option. But in this case, I am less lucky than Sandra, because here in Italy, we have some difficulties in using rituximab in patients with lupus, because it is not only it is not approved, but there is 2 phase 3 randomized controlled trials which showed that it does not work. And so despite the fact that we use it and we ask many times to have it because we know that it's very useful in clinical practice, we cannot have it so easy. And because when we make the request, they said, no, there is 2 trials who said that it does not work, and so we cannot give you the rituximab. And so I think that in this case, so I use sometimes rituximab, especially in patients with nephritis, with refractory nephritis. In the patients like this, just because it is not easy for me to have rituximab, I could prefer to use belimumab, and then if it is not enough, to add some DMARDs, for example, MMF or leflunomide or methotrexate, another one.
There's a point I'd like to ask you, because it struck me. This kind of vasculitis, it really makes us think that is a clinical feature of interferon. And it really strikes the cutaneous vasculitis to make us think that it should have a high interferon in this patient, even if you don't measure it. So being available, would you consider anifrolumab instead of belimumab in these patients?
No experience with anifrolumab, but then based on the fact that it is an interferon inhibitor, so yes, it does make sense. It does make sense for the same reason that you give a sequential rituximab and then move on into a maintenance belimumab. Makes sense. But again, it's on the availability. We'll also have to remember that belimumab has still a longer track record. And it has worked also with vasculitis.
Yeah.
So those are the things that we need to consider. And by the way, in our country, none of these drugs is reimbursable. So it's all of rituximab is off label. So it's, these drugs are being given out of pocket expenses.
Yes, so it's really more difficult to treat patients. Andrea, would you consider anifrolumab?
Yes, also in Italy, the anifrolumab has been approved, but we have not the reimbursability yet. We are waiting for it, but at this moment we haven't. We used, in any case, anifrolumab in 3 patients. We make a request to the for the user compassion use. And we treated with skin manifestations, and really they respond very well, as expected, on the base of the randomized control trial, which showed that it is particularly effective in skin manifestations. And so I think that if the anifrolumab would have been approved, I think that in a case like this, I think that I could use it.
I have a question for you that has nothing to do with this choice of treatments. Do you feel that you should address compliance to the treatment in this patient? Or do you just feel that he's really an awful lupus that is not working, the drugs are not working? Or would you address compliance with this patient, or just go with a severe lupus? Andrea.
The compliance on
drugs.
On azathioprine in the case, because she was treated only with azathioprine and
hydroxychloroquine.
And hydroxychloroquine. But I think that, yes, you mean because she developed flares, especially in the skin, with skin manifestations and musculoskeletal manifestations. It is possible. The data from the French group of Coste d'Ivoire, there are approximately 50% of patients who are not taking the drugs when you go to measure the blood levels. So a very high percentages of patients who do not take completely, or they take in a reduced dosage, so in means not regularly. And so I think that to check to test the adherence of these patients is quite important. In fact, I am thinking also in my hospital to start to measure the blood levels of hydroxychloroquine. I think that it is very important, because sometimes we think that hydroxychloroquine is not working enough, but the reason is because the patient is not taking the drug. And so I think that, yes, Raquel, it is a good point, and I think that we should try to check the adherence of our patients much more than we used to do.
The thing is, it's a first year of diagnosis. She probably is struggling with the new diagnosis of a chronic disease, and she's a young woman. So I think that probably we are missing some conversation and education. And I'm talking to you about my reality. We would like to have nurses helping us with education. It's so important. And the patients going to the patients' organizations to talk about this and know more about the disease. And this struck me because it's a first year of diagnosis. So can you please comment a little bit? I'm going to start with you, Andrea, and then Sandra. How is it working in your hospital? Who is talking to the patients about this? Is the physician? Do you have nurses helping this? Do you refer patients to the patients' organizations?
No, in my hospital, speak with the patient or my collaborator. It is the physician. Not unfortunately, we have not nurses which is dedicated to this kind of activity. Although I think it would be very important. I mentioned before, it is a very good point, and I think that we should try to keep more attention on the adherence.
Sandra, in your context, how does it work?
Absolutely. In our setting, I absolutely agree that communication is so important. Patient education is so important. And very important is the shared decision making.
Yes.
It's so easy to make a prescription, but if the patient doesn't understand what that is for, then the patient will not take it. And lupus is a tricky disease. You take hydroxychloroquine, it doesn't work at once. So it takes time. And steroids work at once, but then it has a lot of long-term side effects. And then after a while, it doesn't work anymore. So hydroxychloroquine is one of those that we need to advise the patient what it is for. And we need also to help them journey through their disease so that they understand why they need to take the drug for a long period of time. And there is a discordance. There is a discordance between what, again, studies have shown that there is this discordance or disconnect between what the doctor thinks and what the patient feels. And we have to bridge that. How do we do that in our setting? Just like Andrea, now we don't have nurses, but it's very important that we teach our students, our trainees, to have that kind of communication with the patient and open communication lines and education. Now, one of the things that has been useful really are our support groups. So we have patient support groups, and they share experiences and how to cope with the disease. So again, it's so important to have a shared decision making with your patient and have that support from other patients, from the community as well, and educate also the community on lupus pain, on SLE as a disease.
And families just...
if I can add, because there is a curious thing that even the name, sometimes we use the name anti-malarials, and this is why we have to take anti-malarials. It is a reason more, because really hydroxychloroquine is probably one of the drugs on which we have to take more attention.
Yes, and she's 34, and we don't know if she has children or not, or if she wants to have more children. So this is also an issue to address. And who addresses this in your clinic? In my clinic, it's me who addresses it at first. And I said, do you want to? We need to solve this. But in your clinic, of course, the patient-physician relationship is really, really important. But in a busy clinic, we don't have time for everything. And we are worried because she's flaring severely. So how do you do this in your clinic, Sandra? How do you get the time to address this?
Oh, I involve my students. I involve my trainees. And that is one advantage of seniority.
Perfect.
It's also a very important thing for them to learn. Which you usually don't get in other situations, but lupus is one area wherein you develop a special relationship with your patient.
Yes.
So yeah, we do that ourselves. And we do have nurses, but we do have a support system in our clinics, but it's still the doctor that's so important to talk to the patient.
Okay. Andrea, do you refer to an obstetrician that has some expertise in this area? Do you do it in your clinic? All
Yes.
this pregnancy counseling and talking about getting pregnant with lupus?
No, we have in this regard a again, also we have no nurses, but we have a joint outpatients clinic with the obstetricians. And so the rheumatologist and the obstetrician see the patients together, and either for the counseling and also during the follow-up of the pregnancy. And I think that is very important to have, a dedicate, as you mean with your question, it is important to have a dedicated obstetricians who, of course, who knows what can be the problem of these patients during their pregnancy, because sometimes they have obstetrical problems, sometimes they have also problems related to their diseases. And so I think that this joint effort is, I think, the most appropriate way to follow up these patients.
And even for counseling. And actually, this patient is not good to have a healthy pregnancy right now. She is severely flaring. So, and we discussed a few minutes ago what was going to be our approach to the patient. And I think that both of you...
If I may add?
Yes.
Another plus factor for hydroxychloroquine. So that truly reinforces the need for hydroxychloroquine. One is it's not good to be pregnant if you have active disease. Hydroxychloroquine is important to control your disease, so you will have better pregnancy outcomes. And the other thing is hydroxychloroquine is safe for pregnancy. So these are the ways you can convince your patient to really adhere and comply with your hydroxychloroquine.
Thank you. Let's go back to the patient. And both of you, during the discussion, said that you would really think on belimumab in this patient due to severe recurrent flare. And she actually had it. She had IV belimumab, was headed to the hydroxychloroquine and steroids. And activity, SLEDAI, was 0 on the next 3, 6, and 9 months later. And 9 months later, she was completely off steroids and serologically negative. So, good experience with belimumab with this patient. Is it, Andrea first, is this a good experience with belimumab? Is your global experience with belimumab? Do all patients respond like this? So good. And do you have in mind what are the main features of those patients who didn't respond to belimumab? Andrea, please.
Yes, I have a good experience with belimumab because, as mentioned before, we have used it in many cases. Also because I think that one of the reasons was that in Italy it cost very low, and it is of course given free of the patients, and so it is very easy to use. And we have also reported our experience, and also with the experience of other colleagues in Italy, because we performed an observational study with where we collected more than 560 something patients. And however, coming back to my personal experience, my experience is very good. What I think is that it is true that sometimes patients taking belimumab can flare because we have seen also in randomized controlled trials, and Sandra knows very well that the frequency of disease relapse decreases during the treatment, but it is not become 0. And so it is possible that patients during the belimumab treatment can flare. But in my opinion, it is not a reason to stop belimumab. Is exactly the same when you treat the patients with hydroxychloroquine. When the patients flare during the hydroxychloroquine therapy, you do not think to stop hydroxychloroquine. What you think is to add an immune suppressant, another one. And so in my view is the same. If the patients flares during belimumab, it is if you think that belimumab is the appropriate treatment for him or her, I think that you have to keep belimumab and maybe to add something else. For example, methotrexate, MMF, or to change the immune suppressant if he is already taken it. If he is taking MMF, maybe it is more appropriate to change to methotrexate. In other words, belimumab is a background treatment, is an immune modulator, which can be in some way to compare to hydroxychloroquine, not as in regard to the cost, of course.
What do you think about it, Sandra? Do you have experience? We know that it's not paid, so the patient has to pay for the treatment. So it's a little bit different. But what's your experience on belimumab response?
Yeah, in the past, in the years that it was available, even as an out of pocket, so patients really pay for it and look forward to having it, receiving it. Because they improve on it. So it's a very good drug. Unfortunately, in the past 5 years, for some reason, it was not available in our country. Not even the intravenous belimumab. For some reason, maybe some administrative reasons. So we read the literature. And as Andrea has said, it is a very long track record. There's so many studies now. Phase 4 studies, experiences with belimumab, and even safety. So efficacy and safety, there's no question that. Now, you asked also, who are the patients who do not respond to belimumab? Yes, there will be always lupus is, you'll never hear the end of it, and every patient is different. So you can have, and that is the reason why we still have unmet needs. So the need for newer therapies, for other therapies, which may not work along the pathway of your bliss, which is inhibited by your belimumab. So here's where now you have interferon-based therapies. You have, for example, the oral that are coming up, your signaling pathways with your JAK inhibitors, or even with your TYK2 inhibitors. So that tells us that there is a need for these treatments for special patients who will not respond to the current treatments that we have. So the other monoclonal antibodies are also being developed for treatment of lupus, and I certainly look forward to that, because there is still that niche for these drugs for patients who do not respond to B-cell directed therapies.
Yes. Do you want to add a comment, Andrea?
Yeah, I agree. Maybe I'm not. I'm not. If I answer properly to your question, the reason is that we use belimumab in patients with mucocutaneous and joint manifestations. Because we also for regarding the nephritis, the belimumab has been approved for nephritis also in Italy, but we have not the reimbursability yet, and so we have not started to use it in nephritis, especially in nephritis. So the majority of our patients are patients with the classical phenotype, mucocutaneous, and what I can tell you is that the concept of non-response is because some of my colleagues, when the patients flare, they think that it is a non-responder to belimumab, but as mentioned before, I'm not so convinced that is the correct approach. I think that maybe it is not enough. Probably belimumab in that case is not enough. So we can also think to change also belimumab, maybe when we will have anifrolumab, or when we will be available the JAK inhibitor, as Sandra mentioned before. Maybe you can also think to change belimumab. but not because it is not working, because it is not working enough.
Yeah.
So
I would like to emphasize the point raised by Andrea, that it probably is not enough. And that is where we'll need to look into belimumab can continue to be used, but we also need the other DMARDs, so the non-biological DMARDs. So maybe this patient would need a combination of MMF with belimumab or leflunomide with belimumab. Now, there are other options also. It's a different story when you have a patient with nephritis. And
Yes,
with nephritis, you have a protocol for that. So you have a fairly straightforward protocol on what immunosuppressive agents would work for that. So that's a world of its own when you now address nephritis. And even if belimumab does work, it does not seem to be still the first choice for patients with very bad nephritis.
So I think we discussed really important issues, and this last part of not wanting the biologic to do everything by its own, since they are expensive, sometimes we have a gut feeling that this is going to be the thing, and then we expect too much from a drug that is not supposed to be the whole thing. So if we choose, as Andrea said, huge experience, great experience, if we choose the right patients to that drug is supposed to be that, and not expecting more from the drugs. You would have a good result. So I think we learned a lot. Thank you so much, Sandra and Andrea, for joining me today and sharing your insights. To our listeners, we hope this discussion have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many colleagues as possible around the world. Join us again next time.